So our next talk is by Christopher Balestrini. Cardiac, autonomic, and cerebrovascular dysregulation throughout clinical recovery and adolescent concussion. And, it's by both of you, and Erin Moir. And this is, you're going to be speaking to some of the work that was set up for you by Dr. Schumacher, is that right?
Yes. Yeah.
Great.
So first of all, Chris and I would just like to thank the organizing committee for inviting us here to speak today. And what we'll be talking about is cardiac autonomic and cerebrovascular dysregulation throughout clinical recovery in concussed adolescents.
So concussion, it's kind of a hot button topic right now. It's why we're all here today. Can even get you played by Alec Baldwin. What we're focusing on in our research is this concept of adolescent concussion. And adolescent concussions are of particular interest to us because they are in a stage of development. Their neck muscles are still developing, some of their brain structures are still developing, and they're also a highly susceptible population due to the nature of adolescence. They're very active, they're active on the playground, they're learning how to ride bikes, getting into various roughhousing and whatnot, just what kids do typically. And this can lead to a higher incidence for a possibility of developing a concussion due to a concussive impact. And what we don't know at this time is what these concussive impacts can do to the developing brain. Some evidence says, as Dr. Iverson showed, that they may be at an improved ability to deal with this concussion, and as the others suggest, that they could be at a detrimental circumstance to it. So what we're talking to you today about is this concept of adolescent concussion and how it relates to two different arms of our study. So I will be talking about the cardiac autonomic dysregulation associated with adolescent concussion, and Erin will be discussing the cerebrovascular function as seen through cerebral autoregulation. So how does the brain affect heart rate? What is this connection? So I'll go through a very brief overview of how the brain controls the heart. Basically, there are certain cortical structures that are going to send projections down to the brainstem and the medulla. Here, we have different branches of the autonomic nervous system, the sympathetic and the parasympathetic branches. In a simplistic view, the parasympathetic system basically slows the heart rate down, whereas the sympathetic system will increase the heart rate. And this can lead to what we call heart rate variability. And an increased variability is a good thing. So you want increased heart rate variability. And this shows that the body and the heart and the brain can respond to external stimuli more readily. So kind of keep that in mind as we go through the talk. And one thing that we're looking at in particular is this concept of short-term heart rate variability as we're measuring through RMSSD, which is the root mean squared of successive differences between R spikes on an ECG signal. And we are using RMSSD because it's reliable over a short-term period of time. And one of the things that we're looking at is once you actually stress the system. So currently there are some literary gaps that we see in concussion, whether it be university-age people or adults, where in supine data, where the system is not being stressed, there are equivocal results. So some show that there is a decrease in autonomic functioning as seen through heart rate variability, and others show no difference. So what we're doing is we are using this dynamic model, as you'll see later, is a sit-to-stand task to kind of tease out these differences in autonomic functioning.
So cerebral autoregulation is an indice of cerebral vascular function because it plays a very major role in regulating cerebral blood flow, both to naturally occurring fluctuations in cerebral perfusion pressure, but also in induced fluctuations to cerebral perfusion pressure. So cerebral autoregulation acts through myogenic, metabolic, as well as neurogenic mechanisms, and it is able to regulate cerebral blood flow and keep it at relatively constant levels within a wide cerebral perfusion pressure range. So anywhere from 50 up to 150 millimeters of mercury, we are able to keep cerebral blood flow relatively constant. Generally, research in the area of cerebral autoregulation and head injury has focused on adults suffering from moderate to severe traumatic brain injuries. Furthermore, these investigations have often employed more steady state or static measures of autoregulation. And these investigations have found that cerebral autoregulation is variably impaired in these populations. However, to date, there is very limited research on cerebral autoregulation in concussion as well as in adolescent populations. In addition, there is also little research out there in these populations using more dynamic models of cerebral autoregulation. So there is a really strong need to evaluate cerebral autoregulation in concussed adolescents, also using more dynamic measures.
So the current objectives of our study are to apply this dynamic model as seen through a sit and stand paradigm that we'll explain, to evaluate the underlying cardiac and cerebrovascular outcomes associated with adolescent concussion. And our goals were to determine the temporal resolution of these cardiac and cerebrovascular outcomes throughout the course of clinical recovery.
So this research tested the hypothesis that using a more dynamic model would expose impaired cardiac autonomic function as well as impaired cerebral vascular function in concussed adolescents when compared to healthy controls.
So I'll discuss a little bit about our participant population now. So our adolescents that we recruit are 12 to 18 years of age. And first what happens is obviously the inciting event, the actual concussive injury. These concussions are diagnosed by professionals at Fowler Kennedy Sports Medicine Clinic, and upon which time they're recruited into our study. We then see them for 2 to 6 weeks, or 2 to 6 appointments that can be biweekly or weekly apart from each other. Our control group is comprised of healthy adolescents that come in for 1 to 2 visits separated by at least 1 week. One benefit to our study is that our control population comes from the exact same sports teams, local sports teams in the London area, that we get our participants from our concussed population. So not only are they age and sex matched controls, but they're also activity level matched controls as well.
So as mentioned, for the current investigation, we utilized a more dynamic model. For this, we used a sit-to-stand model that involved 3 minutes of sitting, followed by 2 minutes of standing, and this was repeated 2 times. And for the investigation, we were interested in looking at 4 different measures. We looked at heart rate, mean arterial blood pressure, mean blood flow velocity, as well as cerebral vascular resistance. And we can see if we start at the top with heart rate, upon standing, there is an immediate increase in heart rate. On the other hand, if we look at mean arterial blood pressure and mean blood flow velocity, we can see that there's a very rapid decrease in both of these measures when they go from sitting to standing. And that rapid decrease also occurs immediately after standing. And then lastly, in looking at cerebral vascular resistance, which we calculated from mean arterial blood pressure and mean blood flow velocity, we can see that it also decreases very rapidly upon standing. Generally, for these measures, it takes about 20 to 30 seconds to return to baseline. You can see just at the very end here, they're starting to return to baseline levels and approach steady state. But for the current investigation, we were interested in this initial phase right after standing, where all of these measures are changing dynamically. So for analysis of cardiac autonomic function, we instrumented participants with a 3-lead electrocardiogram for continuous measures of heart rate. And from there, we were able to calculate RMSSD, as mentioned earlier, our short-term variable of heart rate variability. And for analysis of cerebral autoregulation, we had continuous measures of arterial blood pressure, as well as cerebral blood flow velocity from the right to middle cerebral artery. And using arterial blood pressure and mean blood flow velocity, we're able to calculate the cerebral vascular resistance, as I mentioned. So to measure autoregulation, we calculated what's called rate of regulation. And so that's looking at the rate of change in cerebral vascular resistance relative to the change in arterial blood pressure. So it's providing us information about how quickly our cerebral vessels are able to respond to return cerebral blood flow back to baseline levels.
So now I will discuss our results so far for cardiac autonomic dysregulation that we see in concussed adolescents. So briefly, I just want to go over participant characteristics. And you can see we have 36 controls as well as 36 concussed adolescents. And they do not vary in any characteristic other than SCAT3 symptom and severity score. Another thing that Dr. Iverson mentioned, I just wanted to point out, was that our control group still reported some symptoms and still had, obviously, a severity score associated with it. So here, I'll just orient you quickly. So this is during a sitting baseline, and we have heart rate variability as shown by RMSSD on the y-axis, controls in black, and concussed in the white bars. And we see that the concussed population has a decreased heart rate variability compared to the controls during a baseline sitting condition. So this is a mild orthostatic stress that's imposed on the participants. And we see that this decrease in heart rate variability basically shows that the concussed adolescents are not, the signals are not responding to external stimuli as readily. Just beside it, we see that this is sit number 2, and this basically just shows that the marker is reliable and repeatable throughout our sit to stand, our setting protocols. So here we have the same first 2 bars that we just saw previously, and this shows that the concussed at first visits are reduced compared to the controls in terms of heart rate variability. However, this last bar here, the stripe bar, shows the concussed adolescents at the time of clinical endpoint. So this is when they're actually discharged from clinical care. And we see that there is an increase in heart rate variability from first visit to last visit. And there is no longer a difference between these concussed adolescents at their last visit compared to the control population. So this shows that this can be used as a marker for to track adolescents throughout clinical recovery. So here is just basically when we're actually stressing the system. So this is at the point of maximum physiological stress that we elicit at least. So this is the 10 seconds after they stand up. And here you can see as well, the concussed population is showing a decreased heart rate variability compared to the control population as well. So it's not just an effect that we see in one circumstance. Actually, when the system is being stressed even further, we still see this decrease in heart rate variability among the concussed adolescents. So if heart rate variability is a marker, what about just general heart rate? Because it's an easier measure to understand, and it's easier to measure clinically. And here we see that concussed adolescents in the white bars here versus controls have an increased heart rate at the sitting baseline condition. And this is continued throughout the sit-to-stand protocol. So concussed adolescents exhibit a higher heart rate throughout our full testing protocol. So can we use this as an objective measure to track recovery? And from what we've come up with, the answer is no, we can't use heart rate. Here you see the control population and the initial increase in heart rate at the first visit of the concussed population. And this is at the time of clinical endpoint here in the stripe bars. So at the time of clinical endpoint, there's still an increase that we see in heart rate of the concussed adolescents, showing that it has not improved or it has not recovered throughout the time that they've been discharged from clinical care. So although heart rate variability may be a useful marker in tracking recovery, heart rate may be too simplistic of a measure.
So I'm now going to take you through the results of our analysis of cerebrovascular function. So first of all, some participant characteristics. Our sample size did vary slightly from the sample size you saw that Chris had presented. We did have 27 healthy controls and 22 concussed adolescents. Again, they did not vary in terms of participant demographics. However, the concussed adolescents did score higher on both the symptom score and severity score for the SCAT-3 symptom evaluation. To start off, we're looking at the magnitude in blood pressure drop here. So from baseline levels when they stand up down to the lowest value or the nadir value. And we can see with the controls in black bars and the concussed adolescents in white bars, we saw a very similar drop in mean arterial blood pressure upon standing. In fact, the drop was about 24 to 25 millimeters of mercury. So we see that between both groups, the stimulus to elicit the autoregulatory response was the exact same. However, when we do look at the results for rate of regulation, we see the concussed adolescents at the time of their first visit, here in white, they did demonstrate reduced rate of regulation when compared to the healthy controls seen in the black bars. So that means that when they stand up, they are not able to respond as effectively to return cerebral blood flow velocity back up to baseline levels. Oh, sorry, wrong button. However, when we do follow the concussed adolescents throughout the course of their recovery, we see that at the point of their last visit, here in the striped bars, so at the point they are medically cleared, rate of regulation does improve to values that are similar to that of the healthy controls. So although we do see an impairment in rate of regulation in the concussed adolescents at the time of their first visit, it does appear to improve in accordance with their clinical symptoms.
So in conclusion, we used a dynamic sit-to-stand model to elicit a mild and moderate orthostatic challenge to these concussed adolescents. And what we saw was a reduced heart rate variability, as shown through RMSSD, as well as an impaired cerebral autoregulation in these concussed adolescents. And these may provide to be objective markers to assist in the clinical management of concussion and track these adolescents throughout clinical recovery.
So we'd just like to thank you guys for your attention, and if there's any questions.
I'll ask a question or maybe make a comment. You're in the right place at the right time as young researchers, in my view. This is an understudied area. It's a true gap. And so if you can do thoughtful work in the area of cardio-autonomic changes associated with concussion or cerebrovascular control, this is wide open area. I would encourage you to think about the time course issue. So if this is in fact a biomarker, it might run a variable course in the first month post-injury with a rapidly diminishing signal over the course of the first 5 days, and then something else happening subacutely. So you might see, by mixing people who are 2 or 3 days post with people who are 50 days post, you might be creating a lot of noise in your analysis that you're not quite sure of, that you might be seeing different things in these systems that evolve over a different time course. So I think this, if I were you, I would strongly encourage you to study the first 4 days separately from things that occur thereafter until we get a better handle on it. But if you have any thoughts on time course of the biology, of the neurobiology of this in either the cardio-autonomic system or the autoregulation of your cerebrovasculature, I don't know if you have any thoughts about that. It's a really tough question.
It's a very good question. And it's something that we really have considered a lot throughout our analysis of the results. I'll touch on cerebrovascular function first. So far, when we have kind of tried to separate the groups out into more acute and more PCS, I did not see any differences as of yet. However, we haven't had too many concussed adolescents we've gotten to come into our study that were within the first 4 days. So there certainly might be a difference there that we just haven't been able to see yet.
Yeah, so I guess I'll speak to cardiac autonomic functioning. So I guess the same problem with recruitment as Erin, this is the same study. We see them in a sports medicine clinic, and typically, if we were involved with the emergency room, we may have more acute participants to actually examine. But I don't know if you saw it on our participant characteristics slide. Typically, about 14 to 16 days post-concussion is when we see these people. So yes, if we could get, we do have a fair amount that are under 7 days, but less under that 4-day threshold. But one thing that you did touch on earlier as well, these adolescents, and they may not be as extreme cases as you've seen in the emergency room, but we still see the time of clinical endpoint, and I guess that I just wanted to clarify, is typically on average 3 to 4 weeks after we first see them, plus those 2 weeks initially that we did not see them after their injury. So they're still only returning to these levels of physiological equivalency to the control group at approximately 4 to 5 weeks after initial injury. So that's another point. But yeah, we do want to look at more acute when we get the numbers to tease it out.
Do you have any comparative data with the group at Holland Bloorview or the University of Buffalo where similar studies are going on? as a first question. A second question, you showed us some anatomy at the beginning. Do you have any idea where the altered anatomy is that results in these changes?
So I'll answer the second question first. So there have been previous studies showing that areas such as like the anterior cingulate cortex, the medial prefrontal cortex, and the insular cortex may be involved in parasympathetic functioning. But at this point, so it's kind of been shown in bold imaging that these kind of areas relate to a parasympathetic function, but we're not sure if it's an activation or a deactivating signal that we actually see in the bold imaging. So areas such as those mentioned could be affected, but we have not had a chance to put the concussed adolescents into MRI to really look at that. But those regions may be affected by the concussion. The first question, I don't know. So there is a group from Toronto here that is looking at university-aged people. Also, they just put out a paper on a sit-to-stand model as well, and they're kind of looking more at long-term markers of heart rate variability. And I think with the kind of with an increased sample size, there's definitely some trends leading towards impairment in cardiac autonomic markers. But to our knowledge, we're the first study to really look at these concussed adolescents that are still developing at this point, and to show autonomic dysregulation in these markers.